When I first walked through the doors at the Cancer Center as a patient instead of a nurse, it was very surreal. I'm pretty nervous. Definitely a big day to see if there's any cancer left behind. Yeah, we're definitely hoping for some clean scans. You know, I've always said the waiting is the worst part of cancer. I was definitely shocked to find out that I had diagnosis of stage 3C colorectal cancer. 2 years out is a great accomplishment, but I still feel very close to it. I don't feel like I've beaten anything yet. I'd be lying if I said I didn't act a little differently now with my patients. I think I'm also not afraid to ask the hard questions. Before, I wasn't sure what the hard questions would be. You know, how are you really handling this? How are you coping? Are you sleeping at night? What are you the most afraid of? Those are things that are really scary to get into, but sometimes that cancer patient really does need to kind of talk through that. What does being a cancer survivor mean? How do I just go back and act like none of this happened? So the answer is you can't and you don't. You're a cancer patient forever. It's very comforting to know that I'm in good hands forever.
Welcome to Bench to Bedside, a weekly series of live conversations about recent advances in cancer, from the research bench to treatment at the patient's bedside. And now, your host and the director of the University of Kansas Cancer Center, Dr. Roy Jensen.
Over the past decade, we have seen an alarming increase in the incidence of colorectal cancer among young adults. Research shows that the rate of colorectal cancer has been increasing 1 to 3% annually in people younger than age 50, while decreasing in older individuals. Since 1994, cases of young-onset colorectal cancer, defined as colorectal cancer diagnosed before the age of 50, have increased 51% according to the National Cancer Institute. As a result of this disturbing trend, the American Cancer Society now recommends colorectal cancer screening begin at age 45 for individuals at average risk. In addition, the ACS found that people younger than age 55 are 58% more likely to be diagnosed with late-stage disease than older adults, making cure more difficult. With me to talk about colorectal cancer incidence, improved treatment options, and clinical research taking place is Dr. Anup Kasi, MD, MPH, medical oncologist at the University of Kansas Cancer Center. So Dr. Kasi, does current research provide any indication as to why colorectal cancer rates are increasing among young adults?
Yeah, that's a very pertinent question. And the trend that you described, the increasing incidence, is very disturbing. And if you look at the rates that is projected by the year 2030, we're going to be seeing an increase by 90% for colorectal cancer in the age group 20 to 35. And between the age group 35 to 50, we're going to be seeing 30% increase in the risk of colorectal cancer incidence. Mm-hmm. So there's a lot of discussion going on in terms of the reason, the etiology for the increasing incidence. I don't think we totally understand. Of course, the most common risks are hereditary syndromes, inherited mutations, such as FAP, Lynch syndrome, where there's an increased incidence of colorectal cancer in the young age group. Also, inflammatory bowel disease, such as ulcerative colitis, Crohn's disease, is also a risk factor for early onset colorectal cancer. But there's a lot going on in terms of change in lifestyle, diet, obesity, also in terms of other risk factors that are environmental, including microbiome, bacteria lining the gut. So I think it's a multifactorial reason as to why we're seeing this increased incidence. And I think we need more research. And there's a lot of focused research going on for the same purpose at different institutions. And hopefully down the road, I think we'll have a more accurate answer.
So one trend that's been clear is that in these younger patients diagnosed with colorectal cancer, oftentimes that happens in a setting of advanced disease. Is that because the cancer is more aggressive, because it's being diagnosed and discovered at later stages? Or what is the rationale behind that?
Mm-hmm. Yeah, I think the answer for that is one is the screening, since the age for screening for colorectal cancer was 50 years up until 2018 and now 45 years. So those patients who do develop cancer in their 20s, 30s, or 40s often are not diagnosed until the cancer is spread. So that's part of the reason. But the other reason is also the biology of the cancer. These cancers that develop in young adults is more aggressive, and their mutational landscape of the tumor, the genetic makeup of the tumor is different compared to the cancers that occur in the elderly. So I think both early detection or screening and also the biology of the cancer, both are responsible for late presentation. Half of them, about 50% of the patients, have stage 3 cancers, so it's already spread to the lymph node by the time they present in the young adults, and about 25-30% has spread to other organs when it's stage 4 cancer.
So, considering all of that that you just laid out, does that seem to account for the relatively poor survival rates for colorectal cancer patients that are younger age?
Yeah, I agree. I mean, I think diagnosing them at stage 3, stage 4, then their survival is poorer. In addition to that, since these cancers may not respond that well to the chemotherapies that we have tried and tested and approved for colorectal cancers in the older population, that may not be sufficient to treat our younger patient population. So often in clinic, when I'm seeing young patients with colorectal cancer, I try to be aggressive with our treatments, going with a standard doublet type of chemotherapy that we use for the older patients may not be enough. So we often try 3 triplets or 3 chemotherapy or systemic therapies, and we often look at clinical trials for these patients.
So in a initially, I think, controversial, but ultimately shown to be a wise revision, the American Cancer Society in 2018 revised their guidelines around when to begin colorectal cancer screening. And they moved the age from 50 to 45, even for folks with average risk. Do you think that there's anything else that we can do as physicians to increase awareness about this burgeoning risk for younger patients?
Yeah, no, certainly. I think we need to raise more awareness, and both from the physician standpoint and also the patient standpoint too. Because, I mean, of course, we see these patients when they're already diagnosed and they're referred to us. But, primary care physicians, especially if it's a patient in their 20s, 30s, when they present to them with symptoms like change in bowel habits or abdominal pain, then cancer is not on the radar. It's not on their minds. So I think being more, familiar with the symptoms of colorectal cancer and also being more familiar with the data, with the increasing incidence, I think we need to pay more close attention to those symptoms and then order subsequent workup, whether it's colonoscopies or imaging studies. In fact, I had a patient in clinic yesterday who had been noticing change in bowel habits, some nausea, some abdominal pain that was coming and going for over a year. And he did not seek care. He did not go to his primary care physician. He attributed all of this to diet and work-related stress. But I think from the patient standpoint, I think they also have to be aware of the increasing incidence and seek appropriate medical attention.
Okay. So let's say take the situation where an adult finds that they have bright red blood per rectum, and this is the first time that this has happened. What would you recommend that particular patient in that setting do?
In that setting, I think they need to call their primary care physician and get in to see them for a physical exam, and obviously also get labs, because if there is iron deficiency anemia, then that is probably a long-standing process, though it may be their first episode of blood that they have seen in the stools, but it may have been going on. So if that clinical picture fits a possible diagnosis of colon or rectal cancer, then they would need to be referred for a colonoscopy.
Okay. So I think everybody can recognize bright red blood per rectum. What are the presenting symptoms of, say, a bowel bleed that's happening further up in the colon?
Further up. Sometimes there's just change in the bowel habits in terms of there may be constipation, or sometimes they can also present with watery stools, and also fatigue, because what happens is when you lose blood, then the blood counts also go down with the loss of iron through the blood, and so then that can manifest as fatigue and abdominal pain, because of the tumor sitting in the colon can cause either obstructive symptoms, or if it's putting pressure on other organs, then it can cause abdominal pain. So those would be some of the symptoms that they can watch for.
So if you're just joining us, we're here with medical oncologist Dr. Anup Kasi to talk about colorectal cancer incidence, improved treatment options, and clinical research taking place at the University of Kansas Cancer Center. If you have any questions, post them in the comments below. Remember to share this link with people who may benefit from our discussion. Use the hashtag #BenchToBedside. So the University of Kansas Cancer Center provides a high-risk clinic for patients and their families with a defined history of gastrointestinal cancer and other potential hereditary GI cancer syndromes. Can you tell us a little bit about the high-risk clinic that we have?
Sure, yeah. I mean, the high-risk clinic that we have here is a very unique clinic to the KU Cancer Center. It's hard to find this kind of a clinic and opportunity at other places, where we have patients and even it could be family members without a history of cancer, but they do have a mutation that they carry, which then puts them at a risk of developing GI cancers or other cancers. So for patients like that, we have a separate clinic called the GI High-Risk Clinic, where we see these patients, evaluate them thoroughly, go through their genetic testing results, and then make a personalized plan for them for screening to prevent cancers that they're at risk of developing, or to detect them early if they do develop, and also recommend strategies, whether it could be diet, lifestyle, and there are some clinical trials too that we have going on at the high-risk clinic using fish oil, for example, for patients with Lynch syndrome. So there's a lot of research and attempts that we're utilizing and administering through the high-risk clinic to help this specific patient population.
So Dr. Kasi, as a physician who is involved in conducting clinical research, tell us about some of the trials that you're involved in at the Cancer Center for improving and enhancing the treatment of colorectal cancer.
Yeah, so we do, being an NCI designated cancer center, have a lot of clinical trials, and our goal is to have a clinical trial at every stage of colorectal cancer so that all of our patients can benefit from it. For example, in patients that have early stage colon cancer, stage 2, stage 3 cancers, they undergo surgery, and then we often treat them with what we call as post-operative chemo or adjuvant chemo. And in those patients, we don't know exactly when this cancer would come back. So for those patients, we have a study going on where we're looking at their blood and measuring what we call as circulating tumor DNA and circulating tumor cells, so that we can hopefully detect early recurrence and then act upon it to prolong their survival. In patients where the cancer is already spread to other areas, stage 4 cancers, for example, if there's a cancer spread only to the liver, but what we often do as a standard approach is do chemo and then do surgery and do some more chemo. But we have a trial going on here where we're adding on immune therapy in addition to chemo to improve the outcomes that we are already seeing with our standard treatments. So, and let's say if that doesn't work, and if patients progress on the current standard treatments, then we have several trials where we're combining a targeted treatment with another treatment, which could be immune therapy or a second targeted treatments, wherein we're seeing, we've seen an effect in the early phase trials, and now we're trying to see if we can further improve on it and prove that efficacy. So those trials are ongoing here, and that would be a great opportunity for our patients to participate in. And also, these trials are designed such that they're not chemotherapy-based, and so we're moving from chemo to more targeted and immune-based treatments.
Mm-hmm. So I think the portfolio of trials at an NCI designated center is a pretty obvious reason to come to such a facility. What other advantages would you say are there for patients who come to a center that is NCI designated for the colorectal cancer treatment?
Mm-hmm. So one is, we do have, clinical trials for treatment, as we discussed, that is, from the NCI or from industry. But then the unique opportunity here is we do have investigator-initiated trials, because we as physicians are really seeing the patients here in the community, and we know what their needs are, where the gaps are. And so we've designed some trials which are unique to KU Cancer Center, which is not available elsewhere, and catering to the needs of our community, our patients. So that is, a plus point, being an NCI designated cancer center. In addition to that, I think we have other specialties, other physicians, and other personnel that are involved in the patient's care. For example, a nutritionist. We have a psycho-oncologist on board. We have, of course, case managers, social workers, and we do have, our interventional radiology physicians who help with local regional therapies to the liver, especially. We do have our surgeons who help with surgeries, obviously, but we also do what we call as heated chemotherapy for patients where the colon cancer is spread only within the abdomen but not outside the abdomen. Though we consider that as stage 4, we can still be aggressive and do surgery to get the cancer out, and then treat the abdominal cavity with heated chemotherapy. And we are seeing good responses and good survivals with that approach. Mm-hmm. So I think all those unique opportunities will be available here.
So I'd like to go back just for a second to the whole screening issue. I'm sure most of our viewers have seen the commercials for when you send in a stool sample that's going to look for mutations that are commonly found in colon cancer. Could you talk about that as a screening mechanism, and when is that an appropriate thing to do for our patients?
Yeah, I think there's more and more studies that have been being done in that space, and some of these tools have been approved, which I think are good options for screening. However, I think the downside with that is, let's say that does come back positive, then the patient will still need to undergo a colonoscopy. And so the advantage of doing a colonoscopy is that, one is detection, and if we do find a polyp which is precancerous, and then we get it out, then we prevent that from turning into a cancer. So it's both screening, diagnostic, as well as therapeutic, doing a colonoscopy. And what happens with these stool studies is, it is detecting those mutations, but that may not be still catching polyps or precancerous lesions. It may be detecting cancers in the colon, but at the same time, it will not be able to differentiate between very early stage, precancer, early stage, or if it's spread to the lymph node.
So Dr. Kasi, what would you most like our listeners to take away with them today?
Yeah, I think the most important point is all of us need to realize that the incidence of colorectal cancer in the young adults is increasing. We need to increase awareness regarding that, and then pay close attention to the symptoms and seek care when that happens. And the second point I would like to highlight is that being an NCI designated cancer center, I think it's very useful, very meaningful for the patients to consider getting a second opinion, especially to look for a clinical trial, and in their best interest to get the best care possible.
Well, thank you, Dr. Kasi. That's it for today. To learn more, please visit kucancercenter.org and join us next time for Bench to Bedside. Thanks for watching.